real honor and privilege to be here today. I got to say, I'm really enjoying. I'm seeing everybody in the chat room. They're all, acknowledging themselves. We have the shout out. I don't know about you guys, but it's end of April. It's starting to, really, hope become beautiful in your part of the woods. It's really beautiful down here. And with April, comes all these wonderful things. Baseball's back in the air, and it's always that time of year when we start to think about, what's going on, what's new. And, for us in TB, I don't think a year goes by where we're always, looking at this point of the year of what's happening with, those issues that affect us most. And obviously, I think one of the most important issues that we face is multi-drug resistant TB. And I think you'd agree that, how many years, every year, did we have those lectures about, what's new in MDR TB, only to hear about, unfortunately, things like that the number of cases are going up, the strains are getting worse and worse. And we really didn't have very encouraging or positive news for a long time. But I think you'd agree, over the last couple of years, I think we've seen some breakthroughs and some advances that I think are probably some of the most significant that we've seen in years, if not the most significant. And I think it's only getting more and more, and I think it's happening more and more rapidly. And that's why I think you'd agree that this update on multi-drug resistant, I think, is probably one of the most significant, mainly because I think it's really going to change the way we do not only multi-drug resistant TB, but I think it's going to affect TB in general. And when we talk about multi-drug resistant TB, who's better to be talking about it than Dr. Horsburgh? I mean, as you know, anybody in TB is familiar with Dr. Horsburgh's work. I mean, Dr. Horsburgh's been a leader in tuberculosis for a long time, and for the most part, there's almost no guideline that you can read that Dr. Horsburgh in some way has not influenced. As you know, Dr. Horsburgh has been with National Jewish Hospital. He then went to the CDC and was a leader in both the TB as well as the HIV divisions. He then went from there to Emory, and from Emory to Boston University. And as you know, Dr. Horsburgh has been in public health for over 30 years. He's currently the chair of the Department of Epidemiology at Boston University School of Public Health, as well as he's also holding faculty positions in the Department of Biostatistics as well as the Department of Medicine. As you know, Dr. Horsburgh lectures and teaches throughout the United States and the world, and is very instrumental in TB research in this country and others. I mean, he's currently the National Steering Committee co-chairman of the TB Trials Consortium, and as well as he is intimately involved in the TB Epidemiologic Study Consortium. And as you know, he's also the chairman of the steering committee of the Resist TB, which is an exciting organization. It's an international organization dedicated to improving multi-drug resistant TB treatments through trials. But I have to say, just personally, Dr. Horsburgh has really made a major influence in my life. I remember when I first took the job at A.G. Holly in Lantana, Florida, a small little town. I felt like I was isolated and all alone, especially doing TB in a small little town. It's not the most inviting area you can imagine. And I remember that one day I got this call that Dr. Horsburgh was coming to Lantana to visit me. And I was just blown away. This guy who I've been reading about, he was coming to Florida, and specifically Belgrade, because as you guys remember, during the HIV epidemic, Belgrade was one of the epicenters. And I always remember Dr. Horsburgh coming in and just sitting down with myself, and at the time, Martin the Reader and Elena Hollander, and would just talk to us about his visions of TB, share with us his experiences. And I have to say to you, to this very day, those discussions we've had still inspire me, and they still definitely influence the way I do TB. And I have to tell you that I think that you will agree with me that at the end of this lecture, the information that Dr. Horsburgh is going to share, I think it's also going to be influencing you. And I think that what we hear about today, real soon, we're going to be putting into practice every day in TB. So without further ado, I really want to thank Dr. Horsburgh for sharing this with us. And Dr. Horsburgh, how's beautiful Boston?
It's cold and rainy.
I don't want to say it's cold and rainy, and there's only one other thing that's going on. I was looking at the newspaper today. If I'm correct, the Yankees are in first place right now.
I think it's a statistical aberration.
And since you are, biostatistics is your key, I guess I'm going to have to defer to you on that. But Dr. Horsburgh, thanks again for today.
Sure. David, thank you for those kind words. You set the bar rather high. I'm afraid the tenor of my talk is still going to be that multiple drug-resistant tuberculosis is a pretty scary thing, but I will try to hold out some rays of hope at the end of the talk here. So, as David mentioned, this is my topic, multiple drug-resistant tuberculosis, a threat to global and local public health. And I'm going to sort of talk about a number of things. And by the way, I'm perfectly happy to be interrupted at any time with questions. I have this big screen in front of me, and so if I don't see your question, if someone can point it out to me, I will stop and answer it. I'll also stop a couple times during the talk to ask you all questions, so that's another opportunity for discussion. So I'm first going to just talk about the background of the global TB epidemic, and then talk a little bit about why drug resistance is really threatening global TB control. And then I'm going to move into an area where I talk about what we can do about MDR TB in terms of treatment. And I'll talk about both old and some new drugs that are being looked at. Actually, a couple are now actually clinically available for treatment of MDR TB. I'll also give you an update on the clinical trials that are going on, largely with the new drugs, but in combination with some of the old drugs. And we should have some more interesting results coming out in the next year or two. And then I'll just talk a little bit about what one can do as a clinician to sort of design an MDR TB regimen right now before we really have the results of these clinical trials that tell us really what is likely to be the best regimen for any given patient. So just the basic facts. TB is caused by a bacterium. I have to say this in every talk because even as august a source as the New York Times calls TB a virus about half of the time, but it's not a virus, and it's very important. Bacteria you can see under a microscope, viruses you can't. I think that's actually a very important difference, but it's a bacterium. It's spread via the aerosol route, which means that anyone who has pulmonary TB and is coughing can cough out germs, and so it's really rather difficult to protect yourself against that, and it's one of the reasons that it's such a pervasive pathogen throughout the world. Most of those people who are infected with TB never develop active disease. Only about 10% of those who are infected develop active disease during their lifetime. About 5% do it right away, and this sort of keeps the chain of transmission going. But 5% develop TB much later. It's been documented to happen up to 30 years later, so that people have latent TB that just stays in the body under control by the immune system, but then at some point later on, it reactivates and then they get sick. You can't actually tell the difference between primary disease and reactivation disease. It looks the same, and so that's just one of the things we deal with. We never really know whether this is a recently acquired case or an old case that's just reactivated. But people who have active disease are able to infect an average of 8 to 10 persons if they don't get treated, and that is, again, how TB spreads through a community. This is the disease that TB causes. You can see, I'm going to try to work this little pointer, there we go. You can see that this area of the lung has a white infiltrate. It should look, I think most of you are clinicians and know that, this is what the lung should look like. This white patch should not be there, and if you look closely at this patch, you can see areas where little holes are beginning to occur. This is a pretty classic example of a cavitating lesion in the upper lobe caused by tuberculosis, and TB is one of the few pneumonias that causes this kind of serious destruction. But because it does that, even after you're cured, you may have substantial impairment of the lungs because of the fact that it actually destroys the lungs. Many pneumonias, you get pneumonia, you get antibiotics, it clears up, and the lung heals itself. In this case, it does not. So it's a very destructive pneumonia and explains why it's such a bad thing to have. This is a picture of a smear, and you can see right in the center here, get my arrow back, there we go. This red line there is a bacterium stained with the acid-fast smear, which was developed by Robert Koch about 130 years ago. But that is pretty pathognomonic. There are some non-tuberculous mycobacteria, but most of the time in areas where TB is common, that would be TB. And this is the way the diagnosis is made in many parts of the world, by a smear which shows one of these acid-fast bacteria. This slide shows the stages of tuberculosis and kind of reinforces what I said earlier. If you're exposed to TB, then you will either be infected or not infected, and on the average, about 30% of people with TB become infected, and about 70% escape infection. So it's not the kind of thing, it's not like measles where if you get exposed, everybody's going to get it. TB is a little harder to catch, but if you get exposed enough, you will get it, and 30% of those who get exposed do get it. Then if you're infected, about 5% of those go on to get primary disease, but 95% stay latently infected, and most of those people stay in this persistent latent state for the rest of their life, but as I mentioned, about 5% will eventually reactivate and cause disease. Okay, so this shows the sort of general way that TB exists in the world now. If you consider that we have about 7 billion people in the world, about 4.9 billion of those people are not infected at all, but 2.1 billion people in the current world population are estimated to have infection with TB. So this means that there's a huge reservoir out there of people who may reactivate and go on to getting a new case, an incident case of TB, of which there are 8.6 or so million every year. Also, if these uninfected people are exposed and get infected, they may go directly to disease, or they may stay in this infected pool for some time. People, when they arrive in this pool with active TB disease, will hopefully get treated and get cured and go into the cure box, although a small proportion will relapse and go back into the active case. And unfortunately, there's a fair bit of mortality associated with TB, such that it's estimated by the WHO that 1.3 million people in the world every year die of TB, largely because they didn't get diagnosed at all and therefore didn't get treated, in some cases of treatment failure. This slide shows the distribution of TB throughout the world. It's certainly not uniform. You can see the countries with the darkest blue-green have over 500 cases per 100,000 per year, whereas those with the turquoise are down in the 300, and the lightest color, which the US and Canada and Australia and a number of European countries have, is under 10 cases per 100,000 per year. You can see that the higher incidence rates are concentrated in Africa, some places in South America, and also India, China, and Russia, some of our biggest countries. So that's the distribution, and TB clearly is not equally distributed throughout the world. We have a pretty good regimen for treating TB. This is the standard treatment where you get 2 months of isoniazid, rifampin, pyrazinamide, usually with ethambutol, and then another 4 months of isoniazid and rifampin. And this regimen is extremely effective and, in fact, is able to cure most people who have drug-susceptible TB. And this shows what happens under good treatment over there on the right. You can see this is, let's see, get that arrow going again. There it is. This is what good treatment can do, 95% cures and maybe 3 to 5% relapses. Without treatment at all, we have over 50% of the patients would die. So with untreated, it's a 50% mortality. You actually see about 30% of the people that self-cure. So people with TB can actually self-cure, but there's this other group which of people who are chronic relapsers. They're people who seem to cure, but then they get worse again and they get better again. And this can go on for years or decades. But these people, if not treated, are continuously spreading TB in their environment. And that's why it's a very, not only is there 50% mortality, but those that survive, a high proportion of them are spreading TB in the community. And that's what happens without treatment. So definitely we're happy to have a good treatment program, and yet a good treatment regimen. And yet we still have TB, a substantial amount throughout the world, and we've had that regimen for 40 years. So we have some work to do. This is the data from the WHO showing the global trends in TB incidence and TB deaths over time, starting in 1990 up to pretty much the present. And you can see there was a gradual rise in TB cases, which has pretty much leveled off, and it started to go down slightly over the past 6 or 7 years. The number of people dying with TB has also leveled off and started to decline. And these trends are mirrored among people with HIV infection, both a slight decrease in cases and a decrease in deaths. So I guess the optimist would say we're getting on top of the epidemic, and the pessimist would say we have a long way to go, and those declines are very, very slow. But nonetheless, at least they're declines and not continuing escalation of the rates. This is the actual amount of TB that we see. These are the new cases. I think I said that's 8.6 million cases of new cases of TB each year. Unfortunately, only about 5.6 million of those are diagnosed. So the theme for this year's World TB Day was find the missing 3 million, and these are the missing 3 million. These are the 3 million people who have TB who do not get it diagnosed. And as I mentioned, many of those die. We're doing a much better job of getting those who are diagnosed into care and curing them, but we're missing this group here who aren't getting any treatment because they're not getting diagnosed. Let's see. Okay. Why do we not get people successfully treated? As I mentioned, the big issue is underdiagnosis. And why don't people get diagnosed? Well, there are a number of reasons. One is stigma. In many places of the world, people don't want to get diagnosed with TB. They may suspect they have it. They frequently, unfortunately, don't realize that it's curable, and therefore are afraid to go in and get diagnosed because they think that there's nothing that can be done for them. Or they may not there may not be a diagnostic center in their area where they can go, or they may just not want their neighbors to know that they might have TB, so they don't go. And it may be that the place that they could go didn't have the right tools and couldn't actually make the diagnosis of TB. If the diagnosis is made and the treatment is started but the patient doesn't stay with it, then poor adherence may also lead to a failure of treatment. This is because the treatment that we have, although it's very successful, is 6 months long, so that's a barrier to completion. There's toxicity for many patients, and cost is an issue also for some patients, maybe not so much for the medications, but perhaps for the trips to the clinic to get the medication or be seen for side effects. So there's a number of things that are conspiring to be barriers to TB treatment success. A couple of good things are happening, and this is one of them. There's a new diagnostic modality that is being rolled out throughout the world, which will definitely help us do a better job in diagnosing TB and finding those 3 million, or at least some of those 3 million. It is a test that is done with a machine that detects TB by detecting the DNA. It does it directly from sputum. And in addition to detecting TB, it also identifies whether the patient has rifampin resistance. Now, rifampin resistance is a marker for most of the serious types of drug resistance, and so that's a very valuable thing. Currently, in most parts of the world, the diagnosis of TB is made by looking at a sputum smear. That little smear that I showed you, that picture I showed you right at the beginning, that would be a diagnostic tool. Unfortunately, that's not a very sensitive tool, so 40 to 50% of TB cases are missed with smear, and the GeneXpert test is better than smear, and you can see that by looking here down at this line. Among smear-positive patients who would have been diagnosed by smear anyways, it gets 98% of them. But among smear-negative cases that would be missed by smear, 68% of them are found. So that still means some TB cases will be missed, but it'll be much better than smear at detecting cases. Similarly, HIV-infected people who are often smear-negative, it works pretty well, much better than smear. And it's very good at detecting rifampin resistance when it's present. So it's a real step forward, and the WHO has moved very quickly to try to get these machines out into use. And as of last September, 95 countries had purchased an expert test, and we're getting the cartridges. Each patient has its sputum put in a cartridge for the diagnosis, and these cartridges are provided through WHO at a reduced rate to the diagnostic center. So this really will help us both diagnose the undiagnosed TB and hopefully also more quickly identify people who have drug resistance. So I'm curious to know what people know about GeneXpert, and this is, are the questions somewhere? Do I push a button and get the questions to come up?
Yeah, you're okay right now. Go ahead.
Okay. Oh, I see. There you go. Now the little, so people would vote about this. I'm just curious to know how much people know about this.
So I think it's kind of interesting, Bob. It looks like from here that about 45% of our participants have heard about it but have not directly used it. About 35% it looks like are using it, and about 20%, interestingly enough, this is the first time. So kind of interesting spread across the board.
Yeah, I'm impressed. I actually didn't think its use in the U.S. was as widespread as this. I know WHO has been moving quickly to roll it out. Of course, in the U.S., most diagnosis is made by culture, and culture is actually a little better than GeneXpert, but it's slower. So my guess is that a lot of the use that our participants, who I think mostly are from the U.S., are experiencing is because it provides an answer quickly, which has implications for hospital infection control, and I suspect that's why it is. So this is very interesting. I think that I don't actually know how many people we have and whether everyone's had a chance to vote, but I think this pretty much gives us the picture. So I'm going to turn off the voting and go on with the talk here. Okay, so this shows the global scope of GeneXpert, and you can see here that this shows how many cartridges have been ordered. So some of the dark areas have ordered over 100,000 cartridges. South Africa, which has a huge TB epidemic, and India are obviously big users of this, but you can see many of the sub-Saharan African countries have been using quite a bit of this. Brazil is a pretty good-sized user, the Soviet Union. So this really is moving around. You can see the United States is not a big user compared to the rest of the world. So this really is happening, and it's a real step forward in global TB control. Now, why is TB not under control? There are other things besides diagnosis, and HIV is one of the big areas. You can see here, this is the same cascade I showed you when patients are HIV uninfected. But when patients are HIV infected, a number of things happened. If an HIV-infected person is exposed to TB, they have a much higher risk of becoming infected. If they're infected, they have a higher risk of going on to get primary disease. And if they become latently infected, they have a higher risk of reactivating. The end effect of this is to sort of speed up the process of TB spreading through a community. So instead of sitting here with most people, in this case, most people here not going on to disease but going on to latency, instead they go rapidly to disease. And similarly, instead of staying in latency, they, again, down here, they go rapidly to disease. So you see that when there's HIV in a community, you have much more rapid amplification of the TB epidemic. And this has had a major impact on many TB control programs in areas where HIV is common. You can see here the trends in global TB incidence over time by region. If you remember what I showed you before, the overall trend is sort of a gradually up and then a little over the hump and down, and you can see much of the increase was in this group here between 1990 and 2005, and this is the countries in Africa that have a high prevalence of HIV. These are not just HIV-infected people, but these are countries where the overall TB burden has risen, both because of TB in HIV-infected people and because of TB spreading throughout the community more rapidly. HIV-uninfected people get caught up in this as well. So this has been a major driver of the increase in TB, and as you can see that we have started to get on top of it, and even these countries are starting now to have decreases in new TB cases. But they're still much higher than the rest of the world. Okay, so when a patient has HIV and TB disease, but is not on antiretroviral therapy, I just want to see what people know about when antiretroviral therapy should be started. And you can see the options here are, it's all in relation to the TB treatment. Should you start it within the first 2 weeks? Should you start it by the 8th week? Should you start it after the end of a 6-month course of therapy? Or do you think it depends on some other factors that I didn't tell you about?
Well, Bob, I think we just had a little bit of an issue here. It looks like it may have just gone away.
I was going to say that poll seems to have disappeared.
Yeah, I think the fact that not only did you not maybe tell them about some of the factors there, it seems you actually now made them guess at exactly what the question is and stuff. So
now it's reappeared here. It's back on my.
Actually, there we go.
Okay.
So it looks like about 50, a little over half are saying that they feel about this by the 2nd week of treatment, and then it's that famous good test takers, it depends, 30%. So,
all right. Well, this is actually very. I have a very experienced audience here, because a year or two ago everybody would have said after the end of a 6-month course of treatment, and now that's a pretty uncommon response. The current WHO recommendation is to start antiretroviral therapy as soon as possible. Although, and the reason that it depends is not a bad answer, is that it's particularly important to start it by the 2nd week of treatment in people with very low CD4 counts. So that is sort of a hedge factor. In many parts of the world, the recommendation is that it doesn't need to be started until the 8th week of treatment if the person has a higher CD4 cell count. But there's been several clinical trials that have shown this, and it's not the topic of my talk, but I did want to sort of bring this in at this point to know that it is important to start antiretroviral therapy as soon as possible for patients who have TB and HIV and are not already on antiretroviral therapy. So I'll move on now, if I can make that go away. Okay. The other reason, in addition to HIV and diagnostic shortcomings, that we are having problem with our TB epidemic is drug resistance, and that's really what I'm going to focus the rest of the talk on. So the definition of multiple drug-resistant TB is just this: tuberculosis disease caused by M. tuberculosis resistant to isoniazid and rifampin. And of course, our standard regimen is isoniazid, rifampin, and pyrazinamide. So clearly, when we have a patient who has a that is not susceptible to isoniazid and rifampin, we really have to go back to the drawing board to figure out what we're going to do to treat that patient with. This is a very large and growing problem. Estimated 450,000 new cases of MDR TB each year. Sadly, most of our MDR TB used to come from people who started out with drug-susceptible TB and had a treatment misadventure, as we say, and got converted to drug resistance. But in fact, in many parts of the world now, we see what's called primary drug resistance. That is, people who catch TB and the TB they catch is drug resistant right from the start. Of those 450,000 new cases each year, less than 25% even get to treatment, or even get to treatment for drug resistance. And that's because not only may they not be diagnosed with TB, but even if they are diagnosed with TB, it may not be recognized that their TB is drug resistant. The treatment for drug-resistant TB is much more complicated, and I will be talking about that, but the currently recommended WHO regimen is 18 to 24 months of treatment with 5 to 6 drugs, and even in that scenario, only 60 to 65% of patients are cured, and the mortality can be as high as 15%. So definitely nowhere near the kind of effective regimen that we have for drug-susceptible TB. The currently used regimens, the recommendations, have not actually been systematically studied. These are just sort of recommendations of experts, but a lot of work is going on now to study them systematically, and I'll be talking about that. The so-called second-line drugs, the ones that we have to use in order to treat MDR TB, are not nearly as well tolerated as isoniazid and rifampin. There's substantial toxicity, so the patients not only have to take them for longer, but they have a lot more trouble taking them. And unfortunately, they aren't as good. The regimens that we use for treating MDR TB are not as good at preventing the emergence of resistance, so that between 9 and 15% of patients who are treated with MDR TB will have additional resistance emerge to some of the other drugs while they're being treated. And this definitely has a bad impact on their outcome. This is a graph showing where in the world you're most likely to have TB, a primary case of drug-resistant TB. These are the places where the percentage of new cases of MDR TB can be as high as 28% in the darkest colors, and the turquoise is like 6 to 11. You can see there are quite a few countries, including some of our larger countries, such as China and Russia, that have very substantial amounts of MDR TB being transmitted right from the get-go. These are the areas of the world where there's large numbers of cases where previously treated people have now got the drug-resistant TB, and the percentages are higher. As you can see here, the highest is over 50% of previously treated people in some areas of the former Soviet Union, Russia, and unfortunately a number of other places such as India and Brazil. So big countries that have substantial MDR TB burdens. Now, the more drug resistance you have, the more poorly you do. So this shows the relationship, this graph, between the number of drugs to which your TB is resistant on the bottom, and on the side, the proportion cured. So you can see 0 is not on there. If you don't have any resistance, we get 95% cures. If you only had resistance to 2 drugs, you might have 85% cures. But unfortunately, that's rarely the case. Most people who have MDR TB actually have resistance to more drugs. And so you can see if they're resistant to 3 or 4 drugs, which is probably the most common, only 70%, and then 5 drugs, less than 70% cures. And obviously, if a person develops drug resistance while they're being treated, they're basically moving down this line, and their chances of getting cured are decreasing. This is a question for me. There's no right answer, but I'm wanting to know how many people in the audience have actually participated in the care of a patient with MDR TB.
So I mean, it's kind of interesting here. I think
looks like we have a
is that
experienced audience here.
Yeah, you're having a large amount. I mean, it looks like over 55% of those who are joining us today have, participated in the care of MDR cases, which is, I got to be honest with you, than I thought. I would have thought something smaller. So interesting.
Well, I have to say that one of the reasons I entitled my talk MDR TB, a threat to global and local public health, is that here in Massachusetts, we have had, 0 to 2 cases of MDR TB, new cases each year for like the past 5 years. And in 2013, we had 5 new cases. So we've seen quite an upswing. I don't know, I hope that won't continue, but it is very worrisome. Almost all of our TB comes from abroad, so this means that our visitors are bringing more and more MDR TB into our state. So that this will increase the number of people who have had personally participated in the care of such a patient, and it does look like we're a little over half our audience has done so. So that's good, and I will move on. Okay, thank you. All right, so globally, how good of a job are we doing of getting patients with MDR TB into treatment? So this graph from the WHO is notified cases. So these are diagnosed cases. The cases of TB that are people who are diagnosed with MDR TB, you can see the increases in the number of people who have gotten into MDR TB treatment programs globally. I wasn't able to find a newer version of this, but the projections for 2011, 2012 were pretty accurate. So we're doing a better job year by year at getting people who are diagnosed with TB into TB treatment programs. And there's GLC and non-GLC are 2 different types of treatment programs that have actually been merged together. But the point is that there is increasing capacity for MDR TB treatment globally, and that's important because the drugs that are used are not ones that most clinicians are familiar with, and they have side effects that one needs to be aware of and watch for. The bad news is that this is really just among the notified cases. If you look at the MDR TB overall, I said there's 450,000 new cases, and the gap here, although smaller in numbers, is larger in percent. Really only about a quarter of those are diagnosed, and about 3/4 of the cases that we think are out there fail to get diagnosed. So this is another reason that we hope that the GeneXpert will be very valuable, because it will pick up cases of drug-resistant TB when we weren't expecting them. But I think a big part of this problem is still people not going in and getting treated. Getting diagnosed, and not going in to be diagnosed for TB and therefore not finding out they have drug-resistant TB. We certainly are not doing such a good job at getting all of those who are diagnosed into being cured. We're getting them into treatment, and the shortage here is that our treatment regimens aren't very good. So getting them into treatment only gives you a 60% chance of being cured. And this is why we really need to focus on having better options for treatment that are less toxic and more effective. Okay, so the ball started rolling in 2000 when there was a meeting in Cape Town, which was sponsored by the CDC, the NIH, the World Bank, and the pharmaceutical industry, and they set up a series of institutions to try to improve the diagnosis of MDR, the diagnosis and treatment, particularly the treatment of MDR TB, by setting up several things. The Global Alliance for TB Drug Development is a group that works to try to bring new TB drugs to market. The Global Drug Facility is a central clearinghouse which brings the second-line drugs together to get good pricing, and then provides quality-assured second-line drugs to countries that need them. The Global Laboratory Initiative was focused on increasing the availability of culture, and now also on rolling out the GeneXpert. And the Green Light Committee was a group that it actually doesn't exist anymore, but worked to make sure that groups that were treating MDR TB had the right kind of training and background, so they were giving the right kind of treatment. So this started in 2000, and we have the goal for treatment is to try to come up with regimens that are shorter, don't take 20 to 24 months, that improve on the cure proportion of only 60%, that are better tolerated, and that prevent the emergence of further resistance. And this is what we'd like to see with new regimens for MDR TB. So creating new regimens involves doing a number of things. It'd be great to have all new drugs, but a lot of patients would be out of luck if we waited until we had 3 or 4 new drugs. So we have to think about repurposing some of our old drugs for treatment of patients with MDR TB. What drugs might we think about? Well, there's PZA, and PZA is still a good drug. In about 50% of the patients globally who have MDR TB still are susceptible to PZA. So that's one we're going to want to keep in a regimen, unless the patient is unfortunately in the 50% that doesn't have susceptibility, in which case it's not useful. The fluoroquinolones, and the 2 most commonly available ones now are moxifloxacin and levofloxacin, are called group 3 drugs, and they definitely have a role. They're probably the most active drugs available for treatment of MDR TB. And then a couple of drugs that have not been being used for TB treatment at all, namely Linezolid, which is of the oxazolidinone class, and clofazimine, which is a dye, an old drug that's used for treatment of leprosy, also appears to have some anti-TB activity. Neither of these 2 drugs had previously been used much, and there have been some recent studies which suggest they may be useful, so I will talk about them in just a minute. 3 other drugs that are out there in what are called the WHO Group 5 drugs, which are sort of those about which we know very little, and the amoxicillin clavulanic acid might be a useful drug, but it has to be given 3 times a day, and so it's very rarely used. The imipenem silastin is a drug that has to be given intravenously, and it also is not very frequently used. Clarithromycin is a drug that, personally, I don't think is actually very active at all, and so these last 3 drugs I'm not going to discuss further. I don't think they're really part of the future of MDR TB treatment. A number of studies, however, have looked at the tolerability of the so-called 3rd generation fluoroquinolones, which is largely levofloxacin and moxifloxacin. All the drugs in this class have peripheral neuropathy as a potential side effect and tendon rupture. They're potentially hepatotoxic, and because they're very broad in their antibiotic spectrum, there is the potential for superinfection with C. difficile and C. difficile-associated colitis. But those are not, none of those are very common. They happen 5 to 10% of the time, and given how difficult it is to put together an MDR TB regimen, we pretty much always include one of the 3rd generation fluoroquinolones. Moxifloxacin has another side effect, which by itself is not a major problem, but is something we need to be aware of, and that is what's called QT interval prolongation. So for reasons that we don't understand, moxifloxacin increases the time between the Q wave and the T wave in the electrocardiogram, which is to say it slows cardiac conduction. Now, that in itself wouldn't be a problem, but it turns out if you slow cardiac conduction enough, you get cardiac arrhythmias, a particularly bad arrhythmia, which can lead to sudden death, called torsade de pointe, but that's immaterial. The fact is that we worry about drugs that have QT prolongation. Now, moxifloxacin by itself has only a very small amount of QT prolongation, and using it in a regimen is not a problem unless the patient is on other drugs that have QT prolongation, or you are planning to use other TB drugs that have QT prolongation. And that's why we need to keep that in mind as we go forward. Clofazimine is a drug about which we have a lot of information because we've been using it for leprosy for a long time. It does have this side effect of skin discoloration, which is quite common. It gives a sort of a orangey bronze color to the skin, which is noticeable even among dark-skinned people. And although it is only, in a sense, only cosmetic, it's quite bothersome to many patients. And as I say, it's extremely common. Gastrointestinal intolerance is also seen. Usually that's something you can work around, but clofazimine is not always that well tolerated. And then rarely you see things like eosinophilic enteritis, which is sort of a very bad form of the gastrointestinal intolerance. Interstitial nephritis can occur. It's rare. Rash, dry skin, that happens often, but it usually can be treated with topical things. But clofazimine also causes QT prolongation. Again, it's something that you need to keep in mind. Again, like moxifloxacin, it doesn't cause a whole lot of QT prolongation, but if you use drugs together and that is additive, you can get up into the range where it's pretty dangerous. Clofazimine has been used in TB treatment, and this is a 9-month regimen that was identified in Bangladesh. A group of investigators were trying the various things they could to try to treat patients with MDR TB, and they were actually successful in treating their patients with a 9-month regimen. So this is much better than the 20 to 24-month standard regimen. It involves 7 drugs, 3 of which are given for the first 4 months, and 4 of which are given for the entire 9 months. And clofazimine is one of those drugs. Another drug that's in this regimen, gadifloxacin, is another 3rd-generation fluoroquinolone. It is not available anywhere in the world right now, as far as I know. Basically, it had some side effects with elevating blood sugars that led to its being taken off the market in the U.S., and it's basically not found a niche anywhere, and it's very hard to come by. So this regimen itself cannot be used, although a number of groups are using it, substituting either levofloxacin or moxifloxacin for the gadifloxacin. Interestingly, too, you can see here that isoniazid is in this regimen, and that's because isoniazid, if given at very high doses, is still some isolates that are resistant to isoniazid seem to be susceptible to it at higher doses, and so in this regimen it's given at high doses for the beginning part of the regimen. I actually don't know how important that is to the efficacy of the regimen. I think it's the gadifloxacin, which is also given at a high dose, and the clofazimine, which really make this regimen work. And also, it's not clear, but I suspect that in Bangladesh most of the patients had susceptibility to pyrazinamide. So that's probably why this regimen has worked in Bangladesh. I'll tell you in a little bit about a trial that's trying to determine if this regimen will work in other parts of the world. There are a couple of countries, Cameroon and Togo, I believe, that have been using this regimen with some success. But it's not clear if this will work everywhere for MDR TB, and it may have to do with sort of the underlying background resistance patterns. The regimen, however, as I said, was quite efficacious. You got 84% cures. And in this first series of 206 patients, there were 84 cures, and another 5% who completed but hadn't been followed long enough to know if they'd been cured. You still had 11 deaths, 12 defaults, a failure, and a relapse. But really, compared to what we usually see in MDR TB, this is a very effective regimen. It's also relatively well tolerated, given that it's got some pretty nasty drugs in it. But 206 patients, 21% had vomiting. There were some hearing difficulties because of the high dose of the injectable aminoglycoside. There was a little dysglycemia, presumably related to the gadifloxacin, some ataxia, and moderate and small numbers of other problems. What about Linezolid? Well, Linezolid hasn't seen wide use, but in a European network series, they surveyed their physicians and found 72 cases in which Linezolid was used at a dose of 600 milligrams a day or less. for treatment of MDR TB. And the reason we look at the lower dose is we know from previous experience that when you use linezolid at 1,200 milligrams a day, there's a huge, whopping amount of toxicity, and we don't recommend it. But even in this case, 40% of the patients had peripheral neuropathy, 25% had anemia, 10% had optic neuritis, 10% thrombocytopenia, 2% neutropenia. So this is still a pretty tough drug to tolerate, at least the 600 milligram dose. There is some suggestion that it's still effective now at lower doses, and I heard of someone who was even moving forward trying to use it at 150 milligrams a day. There's really no data on that as to whether it's efficacious or not, and so hopefully someone will study it. But the tolerability is marginal, but when you have a patient that doesn't have other options, this is certainly something you want to think about. Linezolid was actually looked at in a prospective study of patients with XDR-TB. So patients with XDR-TB, and people probably know this, but they have resistance to the fluoroquinolone as well as isoniazid or rifampin. They're resistant to the fluoroquinolones, and they're resistant to at least one of the second-line injectable agents. So these are patients for whom we really have a very poor sort of armamentarium of drugs, and therefore linezolid was looked at in a prospective study. 40 patients were enrolled in the study, and essentially everyone got linezolid added on to a background regimen. But some people got it at the beginning of the trial, and some people had a 3-month delay. And that way you could look at the difference between sort of not getting linezolid for 3 months, and then everyone got it. They were also randomized to 2 different doses of linezolid. I'll show you a graph of how this came out in just a minute. 36 out of the 40 people who had XDR-TB with persistently positive cultures were able to convert their sputum cultures in a mean of 90 days. So this is really an extraordinary result. And the 4 failures were all resistant to linezolid. Given that what we're doing here is adding a single drug to a not very good regimen, which is something we always tell people not to do, it's not surprising that we did see failures and that they were linezolid resistant. I think the amazing thing is we didn't see more than we saw. This is the chart that shows you what they look like. So this is the group that got immediate linezolid, and you can see that starting at about week 2, there were sputum culture conversions, and then up to the end here, it looks like eventually almost 90% of the people converted their sputums. In the delayed group, who didn't get started until day 60, again, starting 2 weeks after the linezolid was introduced, you started to see sputum culture conversion, and it continued on up. So that it was very effective in both groups, and it clearly could be attributed to the introduction of the linezolid. There was no one in the delayed group who converted their culture without the linezolid being added. So it really is a useful drug. It's just not very well tolerated. How well tolerated was it in this trial? Here are the data. As I said, people were randomized to either get it at 600 milligrams a day and stay on 600, or get it at 600 milligrams a day and then drop to 300 after 2 months. In the group that got 600 a day, 60% peripheral neuropathy, even a little more than was seen in the European study, 20% myelosuppression, 10% optic neuropathy. So definitely not an easy thing to do. In those who got the dose reduction, now mind you, they had to go 2 months on 600 milligrams to even get to the dose reduction. But even then, there was 50% peripheral neuropathy, no myelosuppression, and 17% optic neuropathy. So at least at the 600 milligram dose, or at the 600 milligram dropping down to 300, it's still a pretty nasty drug, but it is effective. And for patients who have XDR-TB, it's important to have an effective drug, even if it is poorly tolerated. So what about new drugs? That unfortunately, the review of older drugs that we could repurpose shows us that the reason why those drugs haven't been widely used, they're not very well tolerated. But it gives us some hope that we might be able to combine them, maybe in lower doses, with some of the new drugs. So what about new drugs? Well, since 2000, a lot has happened, and there are a number of drugs that have come forward to be in the TB drug pipeline. And let me just start working backwards, or working forwards. These are compounds that look like they might be useful against TB in the test tube. These are compounds that have gone perhaps through some animal models and still seem to be okay. The mice survived, and it looks like they might actually be effective against the disease TB. And then we move here into phase 1 studies, which is the first in man, when you look to see if the drug can be tolerated, it doesn't have some horrible idiosyncratic side effect that means it can't be used in people. And then we go on here to see if it looks like it's effective against the disease, and what should the dose be. And then here we go into a real phase 3 trial where you prove that as part of a regimen, it's an effective treatment against TB. So the good news is we have a number of agents in these two columns. The bad news is we don't have anything here in phase 1. We have almost nothing here, and everything else is back here in early animal work. So unfortunately, the good news is we have some drugs. The bad news is what we've got to work with now is probably what we're going to have for the next 5 years. And we better hope that we get some useful drugs and regimens. As you can see, gadifloxacin is already over here. It had a phase 3 trial, and yet I told you can't get it anymore. So this is one of the challenges, is if a drug is really toxic, it may not stay in the armamentarium. The good news is we still have moxifloxacin, and we have levofloxacin, which isn't on this because it's not a new drug. But these are agents that we can use in place of gadifloxacin. Rifapentine is a drug that's useful for patients with drugs with isolates that are susceptible to rifampin, and so it's not going to work for us. But there are a number of agents here, and I'll talk about them specifically on the next slide, that are in phase 2 and 3 trials, which really may give us some useful answers very soon. So here is the list of drugs that are currently in clinical development, all in phase 2 and phase 3. They are bedaquiline, which is a diarylquinolone, which Tibotec, which is now Janssen, brought forward. Delaminid, which Otsuka has brought forward. It's an imidazoxazole. These two, PA824 and delaminid, are very similar agents. So although they're technically different, this is an azoxazole and this is an azoxazine, the drugs have a lot of cross-reactivity. They act at the same place. And so one wouldn't want to use the two together, but if one weren't tolerated, you could go to the other. The bedaquiline is in a class by itself. There are no other drugs in this class of drug, although interestingly enough, bedaquiline seems to work similarly to clofazimine. It's not yet known whether the two drugs together are additive, or whether they work in the same place, or whether they interfere with each other. There's no suggestion that they do, but they are different drugs, and so they are different classes of drug. SQ109 is a third new class of drug called ethylene diamine. SQ109 is a tricky drug. It does seem to work very well in vitro. What's not clear in the human trials that have been done so far is whether enough of the drug is absorbed to actually have an effect clinically. Several of these studies have suggested that it doesn't seem to have much effect, at least in the first couple of weeks, in what are called EBA studies. And there aren't a lot of studies going on with SQ109. The company is trying to decide sort of what dose they want to use it at and how they're going to study it. So I don't have too much more to tell you about that one. The last two drugs are two new oxazolidinones, which are in the same class as Linezolid, and which we hope will be equally effective and less toxic. So Sutazolid is a drug that Sequela was developed by Pfizer and acquired by Sequela. And Sutazolid is also they're working on what should the right dose be. So it's in a phase 2 study to try to determine the dose. And AZD5847 is in an earlier phase. They're also trying to find the dose for this one. It's being looked at by AstraZeneca. And GATB, by the way, is the Global Alliance for TB Drug Development that was set up in the wake of the discussions in Cape Town that I mentioned. So these are the drugs that we have potentially available for us, the new drugs. and it is very exciting to think about being able to use them. And the first two, bedaquiline and delamanid, have both been approved for use in the U.S. and in Europe, although the complete approval, I don't think the final approval in Europe is out. But basically, both of these drugs are now available to us on the basis of some preliminary studies and using an approval pathway, which is called conditional approval. So in other words, it looks very good. The final data aren't in, but the FDA or the EMA has been willing to give it some sort of approval, and there are some continuing trials going on to confirm that they're good drugs. But they certainly are available for use, and not widely, but they can be obtained in the countries where they've been approved. You can actually get them through distribution programs. You can't go to your pharmacy and get them, but you can get them. It involves a lot of paperwork. If you are in a country where they're not approved, there are compassionate use programs for bedaquiline. Delamanid has such a program. To date, they've only enrolled 2 people on it, so to say they have a program is stretching it a bit, but they do say they're going to try and gear it up. That remains to be seen. So I'm curious to know, bedaquilin's been available in the United States for about 9 months now. Last June is when it actually, even though it was approved about 15 months ago, it took them 6 months to kind of get it organized and get it out there. And what we're seeing, it looks like, is 7 people. The percentage is going down as everyone else is weighing in. So a few of you have actually been able to get it for your patients. You may not have gotten it, but patients that you had have gotten it. So it is getting out there, although the distribution is quite small. My guess is in the United States, there have been less than 24 patients receive bedaquiline. I don't have data on that, but I don't think the numbers are all that large. There are more patients in Europe. There's, for some reason, been a very large program in France. And it's available, and even I've recently heard that patients in India and I know in South Africa are able to get it through compassionate use. But it looks like most people have not seen patients with bedaquiline. When I said the drug was approved, it is approved for use. It is not recommended except in cases where you have XDR-TB or pre-XDR-TB. In other words, people with MDR TB that really have very few options left. And the reason is that bedaquiline, there is some suggestion of increased number of deaths in the patients with bedaquiline, and that may be why we're not seeing it be rolled out in a great way. There's still some concern about this drug. Obviously, if you have a patient with no other options who has a high risk of death, if they don't get it, then getting it is worth taking that risk of death. It's not clear whether that risk is true or whether it's a statistical phenomenon, and there are some other studies going on, but it's going to be a couple years before we know the answer, and I think that's going to limit the use of bedaquiline. Nonetheless, for some patients, it really can be life-saving. Can we move that poll? Maybe if I move my slide, it'll go away. Okay. So this is the trial that was done that led to the licensure of bedaquiline. It was a phase 2 trial. And basically, these were patients with MDR TB who received bedaquiline. In addition, they received bedaquiline or placebo, both added to an optimized background therapy. In other words, they got all the drugs they could get, and then they either added bedaquiline or you added placebo. The bedaquiline was only used for 6 months, and then there was a long tail of treatment with the background regimen up to 18 months. So essentially getting the WHO recommended regimen. And so half the patients got the optimized background therapy plus bedaquiline, and half got it plus placebo. There were 200 patients. They were going to enroll 200 patients. They ended up enrolling 160 or 161. And the main thing they looked at was the time to sputum culture conversion. So here it is. And you can see that the bedaquiline group, which is the red line, had a much more rapid sputum culture conversion than the placebo group here. So about 70% converted by 12 weeks here, and about 50%, about only 30% had converted in the placebo group, whereas 50% had converted in the bedaquiline group. And this carried on out to, at the end of the 24 weeks of treatment, 79% sputum culture conversion in the bedaquiline group, and only 58% in the placebo group. So it's not perfect. It didn't cure everybody, but it certainly made a difference. And that's really what the FDA was recognizing, and the EMA when they approved this drug, and they said, it clearly is a useful drug. It's adding something. It isn't enough to sort of make everybody cured, but it's definitely something that is worth having in our armamentarium. This just summarizes, and here are the 160 patients. As I said, the cure, and so this now shows data when they followed them out to week 120, and you can see that in the bedaquiline group there were 58% cures. In the placebo group, only 32% cures. So this is not as good as we would have hoped for, because 60% is what we see with the regimen, but this is why you have a control group. It turns out in this study, in the standard regimen, the group that got the WHO standard control, only 32% were cured. So this was a tough group of patients, and the bedaquilines led to 26% increase in cures. So definitely a very useful addition to the regimen. The number of adverse events wasn't that great, only slightly more than placebo, not statistically significant. But this is what we were concerned about. In this group, 13% deaths, and many of the deaths were late, even after bedaquiline, well after bedaquiline had been stopped. In this group, only 2.5% deaths. So there's no real good explanation for this, especially the fact that it happened well after the time that the drug was discontinued. It is hard to attribute it to the drug. Nonetheless, it's a severely statistically significant and worrisome thing, and that's why there's not as much enthusiasm for bedaquiline as there might otherwise be. My personal feeling is probably is not related to the drug, but I wouldn't bet the ranch on it, and I'm glad to know that there are other studies that are following patients longer, following patients on bedaquiline to see if this persists. I don't think it will, but it's a cloud that's going to hang over this drug until it gets resolved. Is bedaquiline well tolerated? Pretty much. About 22% of the patients had nausea, so mild nausea, but in patients with MDR TB, this is it's something we're willing to put up with because it's an effective drug. We don't have good effective drugs. Many of the other drugs we use, like ethionamide, give much more nausea than this, and so it's there, but it's not a showstopper. There were a couple small reports of increased hepatic enzymes. I don't think it's very common. I don't have data on that. But bedaquiline does cause QT prolongation. So you can kind of see how things are adding up now. We have 3 drugs now that cause QT prolongation: clofazimine, moxifloxacin, and bedaquiline. And so obviously that may not be 3 drugs that you're going to want to use together. What about delamanid? This is the second class of drug, and this is the farthest along. I mentioned PAA24, but delamanid has been much better studied, and this is the trial that was done that led to it being approved for use. And this was similar to the trial I described about bedaquiline. This is a trial in which delamanid was added to an optimized background therapy as compared to placebo, and in this trial, a third of the patients got delamanid at 100 milligrams twice a day, a third of them got it at 200 milligrams twice a day, and a third got just the optimized background regimen. 430 patients were enrolled. They were only followed for 8 weeks, so we don't have as much long-term data, although there are safety data on longer duration, but not efficacy data. What we found is that the drug was very efficacious. So this shows this is mycobacterial, culture conversion, and this is in liquid media, and this is in solid media. So just to look at the liquid media, the results are pretty similar. The placebo group had 29% culture conversion. Now this is by the end of 8 weeks, whereas the delamanid groups showed 41 and 45% culture conversion. So again, not everybody converts, but we got definitely some activity here in the solid medium. The higher dose was better than the lower dose. In the liquid medium, we didn't see that. But it's definitely an indication that delamanid is having some antimycobacterial activity, which is something that, and was definitely helping these patients with MDR TB. It's reasonably well tolerated. In fact, it's very well tolerated, except for one problem. It also causes QT prolongation. So now we have a fourth drug, and wouldn't we love to run out there and use delamanid and bedaquiline together? But no one really is keen on doing that. And at the moment, there's actually a trial being organized to study the interactions between delamanid and bedaquiline, particularly with regard to QT prolongation. Because here we have two new classes of agent. They'd be a terrific combination, but nobody really wants to use them together because of concern about this QT issue. So there are a number of trials that are currently going on, which will give us new information quite quickly. This first one is looking at the oxazolidinone AZD5847. It's the dose-ranging trial, which will hopefully tell us that they picked an effective dose and that we can know where we might want to move forward with treating patients. At the moment, we don't have those data. I think we will have those data in about 2 months. The trial is complete. The patients have all been enrolled. The specimens were just recently shipped off to the laboratory to be analyzed, and so I think in 2 months we'll have some answers about that trial. The NC002 trial is a trial looking at PA824, and this is a trial that is also complete and is actually, people have talked about it, but I haven't seen an official presentation of these data. Hold on a second. Actually, right, I have, we should have results sometime this year, and I have a slide that I'll show you on how that trial is organized. The STREAM trial, I have a slide on. The delamanid phase 3 trial, I have a slide on. The OptiQ trial, I don't have a slide on, and I'll just tell you this is a trial to look at increasing doses of levofloxacin. Given that moxifloxacin has a QT problem and levofloxacin doesn't, there's renewed interest in figuring out what's the right dose of levofloxacin. There's pretty good evidence that the doses we currently use are too low and that we could use higher doses, so that's what that trial is going to look at. The NC002 trial that's looking at PA824 is a trial in which patients are given PA at 2 different doses, 100 and 200 milligrams a day, and along with moxifloxacin and PZA. And this is a trial for patients with drug-susceptible TB. But they added an arm because this, since presumably most patients with MDR TB will not be resistant to PA824 since they've never seen it. Most patients with MDR TB are susceptible to moxifloxacin, and at least half are susceptible to PZA. So they would like to know if this regimen works in patients with MDR TB as long as they are fluoroquinolone and PZA susceptible. And then there's another arm which got, my slide got changed around. There's also an arm which looks at standard treatment for drug-susceptible TB and compares the PAMZ regimen. My understanding is that the PAMZ regimen worked pretty well, so I think they will probably move forward with this. This is the Global Alliance sponsored this study, and it enrolled 230 patients. It is complete, and as I say, these results I expect will be presented pretty soon. But this would give us a regimen that would work for some people with drug-resistant TB, probably somewhat under half of them. And so it's a question of whether you're a glass half empty or a glass half full person. But clearly you'd have to have access to susceptibility testing for fluoroquinolones and for PZA, but if you did, this might be a very useful regimen, only 3 drugs that would hopefully be effective. The Alliance is moving forward with a subsequent trial in which they will study patients for 6 months, so a complete course. This is just an 8-week trial to proof of concept. I think they proved the concept, but I don't have data, and that means they're moving forward with a phase 3 trial. The STREAM study is a very important trial that is a phase 3 trial, and it is comparing the Bangladesh regimen, which I mentioned, but substituting moxifloxacin instead of gatifloxacin, and comparing it to the WHO standard regimen of 4 to 5 drugs for 18 to 24 months. This trial is being done in Ethiopia, Vietnam, and South Africa, so it will greatly expand our ability to understand if the regimen can be used, particularly in countries like South Africa, where there's a lot of drug resistance. It's not just or rifampin drug resistance. And so will be very important because obviously even if it doesn't work any better than the standard regimen, if it works as well as the standard regimen in only 9 months, this would be a great boon to treatment. So that is a study that is about 50% enrolled. We don't expect it to be completed and have results for another 2 years, but a very important study that's currently going on. The delaminid phase 3 trial is another important study. Remember, I showed you the data on how well delaminid worked when added to optimized background therapy over 8 weeks. This trial will study now the addition of delaminid to optimized background therapy when the delaminid is added for 6 months, and then there's an 18-month tail of OBT. There'll be 2 doses of delaminid and placebo arm, which of course will get 24 months of optimized background therapy. And this trial is completely enrolled. So the patients are still being treated. At the end of 6 months of treatment, I think the last patient will complete the 6 months of treatment late this fall, and we expect to have results on the effect in the first 6 months of treatment next year. Obviously, the effect after the completed course of treatment will not be available for a couple of years after that. But this is the confirmatory trial that is part of the accelerated approval process. But this should certainly be a very valuable addition and would give us a better regimen, although not a shorter regimen, for treatment of MDR TB, because you're still treating 18 to 24 months. So by having the delaminid up front, you might be speeding the time to culture conversion and hopefully increasing the overall proportion of patients who are cured. So how can we use all this information to construct a new MDR TB regimen? Well, there's no hard and fast rules, but common sense would tell us that we need to have at least 3 drug classes that the patient's isolate is susceptible to. So if you have susceptibility data, it's very easy to know what that is. If you don't have susceptibility data, then you'd like to have 3 brand new drug classes. In most cases, at this point in time, Linezolid and Clofazimine would be considered new drugs for the purposes of most patients. Unless the patient had been treated for leprosy in the past, you could assume their isolate would be susceptible. So you could put those into the mix in terms of picking 3 new drug classes. Obviously, if you knew you still had susceptibility to an injectable agent or another second-line agent, you might want to use it. But by and large, we're thinking 3 new drug classes, and that doesn't include PZA because, as I said, 50% of the patients don't have susceptibility to PZA. You'd want to avoid overlapping toxicities. So the most important, obviously, as I led you down the path here, is the QT toxicity. There's a lot of concern about that. Nausea is probably the other very rate-limiting toxicity. If you're making people nauseated with more than 1 drug, you're probably going to have them throwing up all the drugs. The other things to be concerned about are hepatotoxicity and bone marrow suppression, which several of the agents can do. So it's very important to monitor these patients. And that may be one of the things that limits your choice of a regimen. We would love to move to an all-oral regimen. I'm not sure we're there yet. If you still have an injectable agent, these are good agents, but in the long run, that's not something we want to keep in our regimens because of the toxicity of the repeated injections, because of the pretty high frequency of hearing loss, and because many of these patients are quite thin, so that even giving them injections can be very challenging. And then we'd like to use the 2-month sputum culture conversion as an indication that we're doing the job, but many of these patients don't convert their sputum in 2 months, and we have to soldier on anyways. These are what we have to work from. this is sort of the menu of drugs that we might use to treat patients with MDR TB. The diarylquinolones is the bedaquiline, nitroimidazole derivatives, delaminid or PA, and I mentioned you wouldn't use both. Same with the oxazolidinones. One of these, Linezolid, perhaps Utazolid or AZD. There are others out there that are coming to market. None of them have been studied for TB, and at this point I think I wouldn't go there, but if you don't have access to Linezolid for some reason and you do have access to Tadazolid or something else, by all means give it a try, but there are no data. The fluoroquinolone class, levofloxacin and moxifloxacin, I would not use ciprofloxacin. I would not use ofloxacin because it's basically the same as levofloxacin, and you just have to give more pills to get the same amount of drug in. Gatifloxacin you can't use, so those are your options there. The raminophenazines, clofazimine is the only one we have, and other, as I mentioned, I would basically always keep PZA in the regimen until I knew that the patient had resistance, at which point I would stop it. So you're going to try to pick 3 new drugs, not counting the PZA, and you have 4 classes to choose from. So there's no easy choices, and I'm not going to give of my favorite regimen. I don't have a favorite regimen. There are a number of trials going on that are trying to look at whether some of these combinations that put together, particularly drugs with QT toxicity, are okay. I mean, could we, for instance, use a backbone of bedaquiline plus delaminid? We'd like to think so. Now, PA824 doesn't seem to have a QT signal, so the bedaquiline PA824 combination is an attractive one, and there is a trial moving forward in the ACTG looking at those 2 drugs plus various other background drugs, including levofloxacin and Linezolid, to try to come up with a regimen that had minimal toxicity. But we won't have any answers for that one in the really near future either. Other trials, that by the way is the MARVEL trial. The bedaquiline is also putting together a phase 3 trial. I mentioned that we have data on people treated for 6 months, but there's a larger trial being organized, probably going to turn out to be an addition of arms to the STREAM trial, which included bedaquiline for either 6 or 9 months. So that's something that's in the works. There's the MARVEL trial in which bedaquiline is combined with PA824 is in the works. The drug-drug interaction study between bedaquiline and delaminid is also moving on a fast track. The PAMZ study I mentioned, they're now doing the 6-month study of PAMZ. And the NIX-TB study, which is a study for XDR-TB, will combine bedaquiline, PA824, Linezolid, and PZA in a study for XDR-TB that will occur in South Africa. So those trials will be happening, and it is a very exciting time, but we're not going to have answers in the near future. So just to sum up, we have new TB drug classes that may increase treatment response rates and may also allow us to shorten treatment duration and decrease mortality in patients with MDR TB. The tolerability of a number of the new agents remains to be defined. They've only been studied in a small number of patients, and so there is the risk that some very serious toxicities, uncommon but serious, might show up, and we need to be on the lookout for those. We do need combination studies to make sure that the new drugs can be used together with each other and to be used with antiretrovirals. Almost half of the patients with MDR TB globally have HIV infection, and therefore they need to be treated with antiretrovirals, and so we need to have regimens that can be used along with the currently used antiretrovirals. The trials that are currently in progress and under consideration will hopefully clarify a number of these drug-drug interaction and toxicity issues. And a major challenge is going to be preventing the emergence of resistance to the new drugs. I showed you how easy it was for emergence of resistance to Linezolid. 40 patients got it and 4 patients showed up with resistance. So if they're not used correctly, this could be a big problem, and we might not get as much benefit out of these new drugs. And lastly, if we're going to study all these new drugs in MDR TB, we're going to need increased capacity for clinical trials so that we can do these trials quickly, and several of the networks are currently expanding their ability to gain access to patients with MDR TB and do clinical trials, so we can get those responses, those answers as quickly as possible. So that's the end of my presentation, and I'm more than happy to have questions. So I'll turn it back to our moderator, Dr. Ashkin.
Dr. Horsburgh, that was absolutely fantastic. Thank you so much. And we got a ton of questions, actually. But just for everybody who's participating and joining us, just to remind you, thank you so much for entering the questions, and I'm going to start asking them. But also, we'd love to hear from you. So if it's okay, if you look at the top left, you'll see a guy raising his hand. That's the place if you need to go to, no, that's not about a bathroom clip. But actually, if you click on that, what's going to do is it's actually, you'll see on the side, it'll be a place where you can raise your hand. And we'll then know you're raising your hand, you have a question. And then if you want, we'd love to have you just push the *7 to unmute and then ask your question to Dr. Horsburgh. So we're going to go back and forth between the questions that came to us via the chat as well as some questions live, if that's okay. And I'll ask for the questions live by your hand. So again, just push that little button, the arrow next to the guy raising his hand, push raise your hand. We'll then see you, and then I'll call on you, and we'd love to hear from you guys. So, Dr. Horsburgh, we got a number of questions, but if it's okay with you, I'd like to start with just some of the questions early on that were being asked about the GeneXpert. You know, and it was kind of interesting to me, I think you'd agree, about the GeneXpert. Not as many people, I would thought, have really been utilizing or have access to the GeneXpert. I got to be honest with you, in the United States, for us, where MDR is much lower, the GeneXpert for us, at least here in Florida, we don't use as much, mainly because while rifampin resistance is really important and is obviously a marker for MDR, we're just as concerned about INH, which the current version of the GeneXpert doesn't tell us. And the reason we're very, very interested in INH resistance is that for most of, first of all, INH resistance is more common. And also, we're always worried about how should we treat our contacts, But I guess the question, we have a number of questions about, first of all, the GeneXpert and how was it developed and who paid for it. Do you want to talk about that a little?
Well, it was developed by a group of scientists who had done work on DNA amplification, and then what they were able to do was to put it together in sort of a package. I mean, the advantage of GeneXpert is it's no muss, no fuss. Everything is in a container. You put the specimen in, all the reagents are there. You don't have to have a special training. You don't have to have a special facility. You just plug it in a machine and it gives you an answer. So that's really the beauty of it. The technology is, the actual diagnosis by DNA detection is pretty straightforward, but it's always been necessary to have a special laboratory to do it up till now. That's what makes it advantageous. And so in places where there's no access to culture, basically kind of jumped over culture and gone directly to this. And this is why I think it doesn't have such a wide rollout in the United States. If you have access to culture, then the only thing that GeneXpert gives you is speed. And that's why I suspect the main place it's being used is to show that people don't have TB and get them out of isolation so the hospital can save some money. And that, of course, you wouldn't want to wait 3 to 6 weeks for your negative culture.
I have to tell you that it's so funny you should say that, because I really have been pretty surprised, actually, that we're still not using PCR to get our guys off of isolation, and that the guidelines still pretty much are recommending smears. We did a study down in Miami that showed that the PCR would have been a much quicker way and more accurate way to get people off of isolation. I was hoping with that study, to be honest with you, Dr. Horsburgh, that maybe if we gave hospitals the incentive to do PCR at a point of contact, that we would have more access to, tests like the GeneXpert and PCR. But I think you're right. I mean, I don't see, I'm kind of disappointed I don't see as much use of the PCR to make decisions as far as isolation. Are you doing that more in Boston, or do you know areas where they are?
No, I don't think it's that widely available. I mean, I think only hospitals that see a lot of patients potentially with TB are going to have an interest in having it available. There's you have to have a certain volume to have the test make it worth having it.
But interestingly enough, I do agree with you. You need to have some, but I think you'd agree, obviously, even though you may not have a lot of TB, I would say a lot of areas of the United States still are ruling out TB. Obviously, we're ruling out a lot more TB than we're ruling in, I hope. And, you would think that that would be an incentive for, getting the PCR out more. But you're right, it's not being used as much. I guess along that lines, one of the questions we had was, it's about the cost of the GeneXpert. And, I understand that in the United States it costs about $60,000 for the machine, and the cartridges run anywhere about $30 to $40 each, if I'm correct. But I know, Dr. Horsburgh, if I'm correct, that around the world there is some, quote-unquote, agreed-upon prices to try to lower that. Are you aware of that? And
yeah, I think the WHO qualifying price is down to $10 a cartridge now, and I'm pretty sure that many of the machines are donated. So the cost is not a major barrier. I mean, it is a big barrier, obviously, but in many of the countries have the kind of resources that they can pay for that. The very poorest countries still are challenged to come up with that kind of money.
And I have to say that, one of the reasons I said that I think this is the most exciting and times right now is that for the longest period of time, there was just no interest in TB. There was no money. And actually, like you alluded to, the development of the GeneXpert, the development of some of the new drugs really were pushed by, a group of individuals around the world, guys like Bill Gates, who really tried to push now for trying to get answers to TB. And I think we're starting to see some of the fruits of those efforts. I really do think, like you said, that not only just developing the GeneXpert, but getting, encouraging the companies and the countries to work together to bring the price down and to increase the access has been exciting. We also have we have some questions also about clofazimine, and we're going to go through in a couple minutes. If we have any questions, by phone. But one of the questions about clofazimine was the skin discoloration that you get. Is that reversible, Dr. Horsburgh?
Yes, it's completely reversible. It takes a long time, though. Clofazimine builds up in the and it can build up to just incredible levels. But it's a dye. I mean, the medicine itself is a dye, but it doesn't permanently stain. So over time, it can take 6 to 12 months after stopping it to get it out of the body. Discoloration does go away. So that means you're going to look funny for a couple of years.
Well, I also think that's one of the problems. I mean, at least experience. I mean, I know, certain studies have come out and showed that there was real advantage to using clofazimine in the regimens. But, clinically, it takes, if I'm correct, it takes quite a long time to build up those levels because it is so lipid soluble. It is a dye. I mean, if I'm correct, I always wondered about those studies, as far as especially using it in the first 2 months. My understanding is that, given the pharmacokinetics of the clofazimine, it takes some time.
Yeah, I don't think it really became active until about the third month of treatment. But I think that's why in the Bangladesh regimen it's pretty good, because you have a whole bunch of other drugs for the first 4, and by the time you stop those, the clofazimine is kicked in and is helping with 3 drugs that stay in the regimen. So I agree. If you were to make a decision based on the effectiveness in the first couple of months, you'd never even consider clofazimine, and I think that's one of the reasons it got left out.
Yeah, I mean, and, talk about other drugs that kind of got left out. We got a couple of questions coming in about drugs that, we don't talk about too much. One in particular, cycloserine. And Dr. Horsburgh, I'm kind of a cycloserine fan. I know I'm out there on the other end, but I always felt that cycloserine, the way it was being used at 250 milligrams 4 times a day, really increased toxicity, and actually in some cases precluded its use. Almost like with PZA when we're using higher doses. Any comment on cycloserine as far as the drug and where you see it in use in MDR cases?
Great question. I can't say cycloserine, but the reason is some pretty bad side reactions in patients who, and the difficulty I have with cycloserine is is you never quite know when a patient is going to like have a psychotic break or go, get suicidal. It doesn't seem to be related to the dose of the drug. Your question is a good one about whether we could use it at lower doses. The pharmacokinetics would suggest it's a static drug, therefore keep giving it. On the other hand, it can replicate very fast. Maybe low doses at once a day would work, but it just, my overall take is we almost never see patients develop serine resistance. That suggests to me that it probably isn't doing much.
Or that nobody
therefore driving patients to resistance. But it's been well studied, but I just find the psychiatric side effects are so challenging that I'd like to avoid going there if at all possible.
Yeah, I mean, we use a low dose, and again, in our experience, in what we published in our, that using it, in context of a multi-drug regimen, and I think that's really the issue because you never know which drug is working. It seems to work with less side effects, but you are right. The psychiatric, is definitely there, and you're always worried about it. The other drug that, people are asking about is the proethionine, what I like to call ethionamide in this country, but in other countries is proethionamide, and they wanted to know is it any different than ethionamide? Is it available in this country?
It's not available in this country. It is the same drug. So, in some countries you get proethionamide, and some other countries you get ethionamide. They're essentially the same drug. Both have pretty substantial GI toxicity. They work reasonably well. The toxicity is the limitation. Just getting the drug into the patients without them vomiting it back up can be very, very challenging.
Talk about like GI toxicity. That was the other drug that people were wondering about was. I mean, in my experience, that's the biggest problem with ethionamide and PAS, and why two reasons I don't really like using them. One is that, for public health where we do DOT and where we really like a once-a-day regimen, both of those drugs have to be given more than one time a day. And the other problem is as you stated, I mean, I find that my biggest problem is once I get it in, it all comes back up, and not only does it come back, do those drugs come back, but it brings everything else up with it. So how do you...
I couldn't agree with you more. Part of my talk say, what do we do once, I mean, if patients can tolerate and benefit from PAS and cycloserine and ethionamide, and they're getting better, great, but that's not very many patients.
Yeah, I agree. I mean, I think it's a real sell for how many GI, how much like antiemetics can you give, but, that's better drugs. Hey, why don't we 1 second, and I know we have call with individuals who wanted to ask you a question. So, John, I know John Walkinson's out there. I like John just because I think he's a hippie, as you know. He has that really long hair, and so out there, it's *7 to unmute. Whoop, I don't like my comment.
Hello.
I think John wanted to ask you if I'm correct. John, are you there?
Yes, yeah. I am. Yes, I am.
Hey, John, how's it going?
Hey, thanks for the kind words, Dave. Dr. Horsburgh, thanks for...
I had a question for Dr. Horsburgh. What question you got?
Yeah, I've got two quick ones. First, Dr. Horsburgh, can you discuss the reason that HIV-positive individuals are at higher risk of TB infection if exposed than HIV-negative persons? And my second question is, do you think that all of the guys in the blue man group are secretly taking high doses of clofazimine?
I don't know what turns you blue, so I can't answer the latter question. The former question, now remind me again. So, sorry, what was your first question?
Please discuss the reason that HIV-positive individuals are at a higher risk of TB infection than exposed.
I can't definitively say that. Observationally, it looks like there is a higher risk of infection/disease. There haven't been any really sort of careful studies done. It's a difficult thing to study. But the same immunologic mechanisms that prevent you from going from infection to disease are to be the ones that prevent you from fighting off infection at the beginning when you're exposed or not. So it's thought that it's the same immunologic deficiencies that lead you to be at a higher risk of infected if exposed. So, take fewer bugs, for instance, to infect somebody who had HIV infection because they don't have the immune defenses. That's the theory. But there's not a lot of good data.
Yeah, I think we all agree. I mean, we always kind of make that, but you're right. When you look at the data, it's kind of hard to really definitively prove. And I totally agree. I think it's a great point. John, thank you so much. Hey, again, anybody who has a question, just push to raise your hand. Just push *6, unmute yourself, and *7 to unmute, *6 to mute again. But ask a question. We'll stop in a couple minutes and ask for more questions. But we really rather hear you. It's so much better, and this way we can have a conversation. So thank you. Dr. Horsburgh, I mean, when we talk about all these questions about MDR, new drugs, and regimens, everybody has the same questions. Okay, this is all great, but how much does it cost? So, as we're aware, and as you pointed out, bedaquiline is now available. You can go to you can order it, you can get it. But I think one of the biggest issues is how much does it cost for a regimen, bedaquiline?
Okay, in the United States, 6 months of bedaquiline, you don't have to buy all 6 months at once, but the total would be about $24,000. So that's a pretty substantial thing to bite off on. Gelaminid hasn't been priced yet, but my understanding is it will come in a similar range. Now, I don't know where that will go. Clearly, not going to sell enough of it to make very much money. So why are they pricing it so high? Well, there are theories about how drugs are priced, but it's high.
And that's really been, for a lot of us in public health, that's definitely been a limiting factor. About how much we use bedaquiline, and I think obviously we have other options, but one of the big issues also is cost. But obviously, if the person's not getting better, you're going to do what you can do. And one of the questions that's also being asked, Kathleen just asked about, which I think is very, very interesting, and we don't talk too much about it, is what do you do with patients who are MDR, who have MDR and don't respond to treatment, and you're unable to cure?
Well, obviously there's a risk to them spreading infection to other people. So they really need to use barrier precautions, and we need to make sure they need to be careful about where they go and what they do, because they are at risk for exposing other people.
Yeah, I mean, when I first started at AG Holly, soon after, right before I met you, we had a couple patients that were actually court-ordered quarantine because they did have strains of TB, at least at that time, that they couldn't treat, and they were exposing other individuals. So it is a major issue. That's why it's such a pressing issue that we find ways to treat everybody. One of the questions we're getting also is about the peripheral neuropathy. I mean, for us, Linezolid has really been a very important, addition to our regimens and to our armamentarium. But the biggest issue is the peripheral neuropathy. So I guess a couple questions we have about the peripheral neuropathy, if I can, is one is it like INH or cycloserine? Is it B6, in B6, not dependent, but can it be maybe prevented with the addition of B6?
I think using B6 is a good idea, but I actually don't know of any data that the linezolid-related neuropathy works via B6 mechanism. The important thing to know about it is that it's reversible if you recognize it and stop the drug early. It can become permanent if you don't. So that limits the use of the drug.
And I think that was the second, one of the other questions is, and I agree with you. I mean, we've seen, first of all, it's not just a peripheral neuropathy, it is a neuropathy. I mean, I've seen it, we've seen people have problems with their hearing, I've seen have problems with their taste, their tongue. I mean, it's serious and it may not be reversible. And, I appreciate what you said. You got to catch it early, you got to be asking the patient constantly. And I guess the question always then becomes more excited, is like, and you kind of touched on it, but just to allude is, what about lower dose linezolid? You talked about, 300 and even 150. People were interested is that, two things. The neuropathy, still continues to occur, but, we don't know if there's really a difference between the occurrence. And also, one of the interesting things you mentioned, and some individuals are asking for more insight into is, it seems the optic neuritis went up with the low dose. Do you think that's true, or what's your comments on that?
Oh, that was just small numbers. That's not a statistically significant difference. There were just very few people in that group. What I'm told, and I've talked to people around the world who are using linezolid and MDR TB treatment, is that they feel that the 600 a day just gets you into too much trouble, and from a program point of view, it's not worth it. So they've backed down to 300. We really don't have good data on how effective it is, but at least we know it can be tolerated. The ACTG trial is actually going to use 300 and study it. I know of no data about 150. I just talked to somebody a couple days ago who said he'd heard something about 150, and I said, can you get me some numbers? And I haven't got them yet. So I don't think that's realistic, but 300 seems to be something that a number of international programs that have large amounts of, particularly in South Africa where they have access to linezolid, which they're using. And it's purely because it's not as toxic. And it may go along with your idea about cycloserine. It might contribute to the regimen even though it would be better at a higher dose since it can't be tolerated. They're just not going there.
So, and I agree. And so we opened up the famous can of worms. I mean, what drives me nuts sometimes about TB is this whole concept that everybody gets treated the same way and one size fits all. And I think that's one of the biggest issues, and I'm going to open up this as a concept. I want to hear how you feel about it. One of the differences between the international trials and U.S. treatment, I mean, in the U.S. we're much more towards an individualized, and even studies outside the U.S. have shown that individualized treatment, meaning basing it on the susceptibility profile, seems to be better. But I think also at the same time is that this whole concept 300, 600, I think it kind of, and I'm not an ID guy, I'm going to turn this over to you as but it just doesn't go along with everything else we treat, especially other bacteria, where we're really much more looking at the MICs of the organism and then look at the serum drug levels in order to try to maximize the treatment. And I know it's intensive, I know it's expensive, but it kind of just gets me sometimes, especially in these drugs, that we're not looking at how to maximize drugs and minimize side effects based on the MICs, which are now becoming more available, and based on serum drug levels. What do you think about that? What's your comment?
Well, in theory, it's a great idea. The challenge is doing it in practice when you're using several drugs at once, because you not only have overlapping toxicities, you have overlapping efficacy. And so, how much bang do you need? Well, you need enough to make sure that the patient's getting better. I mean, and so while I agree with you that in theory we could really study people intensively and optimize the dose of every drug, it's not a practical solution because we have so many different drugs. So,
right. I mean, but even here, I mean, where we're getting to the point, even with certain, numerous drugs, you are right. In the past, it was hard to measure the different levels all at once, but now with more liquid chromatography and the ability to separate out, we're getting better levels. But I think you're right. I think practically for the rest of the world, I don't think it's going to be an issue. But I think it's something that, I would like us to sometimes think about and talk about on individual cases where not all organisms are the same, and each one may have different susceptibilities and different levels of inhibition, and we should, I believe, sometimes talk about that. I think it's something, that's important. Towards that end, one of the questions that are being asked is not only just for the patient, and I know it's a little beyond this, but, for the contacts, and one of the questions is the famous question, and I guess we have to touch upon it, even though is, do any of these drugs, I think it's too early, do any of them have any kind of potential for prevention of LTI, of latent tuberculosis infection in context of MDR? And even in those, the famous question, how do you treat, let's say you do have an MDR case, there's a couple of basic, some questions on how would you treat them, and do you treat them, or do you say, go for the famous observe, and do you use INH in addition to, let's say, treatment for, MDR in context?
Right. Well, this is a thorny issue, and we're in a data-free zone. So, in theory, if I had somebody who was at high risk, I would treat them with some kind of a regimen based on what the source case's susceptibility was. Using INH depends on what the chances are that they might have gotten infected with TB by somebody else. So it kind of depends on how much you think they were really mostly exposed to the source case. If they're in the United States, they probably weren't exposed to TB anywhere else. If they're living in a barrio in Rio, then there's a good chance they got exposed to TB from someplace else. So it really depends on the situation. As far as the new drugs, a number of them look promising, but until we have a better idea of the safety profile, I don't think we're going to be able to study that. So for instance, bedaquiline might be a great drug to treat contacts of people with MDR TB, but 22% of the people had nausea. Now, if you have MDR TB, what's a little nausea? But if you feel fine, a little nausea might be not. So you're looking for a much higher safety profile. So until we have a bigger safety database and know that, by and large, this drug is really pretty well tolerated, we're not going to be able to go to trials of seeing if it can be used for preventive therapy.
Yeah, but, again, this is, as we're always dealing, at least, again, the international issues, where concentration is mainly in the treatment, I think these are important issues, and you're right, everything changes, because when you have disease, you're much more willing to tolerate a lot more side effects than without it. We have a question, actually, a basic question just about MDR in the United States, especially primary MDR TB, do you know offhand or approximately, what's the percentage of patients with MDR being diagnosed in the U.S. are actually U.S.-born versus foreign-born?
I'd say it's infinitesimal. Almost all the patients are foreign-born.
I agree. I think, if I'm correct, I think hearing that only about, around 15 to 20% U.S.-born. And, you're right. I mean, this is really an issue of individuals who are getting exposed for the most part in other countries. And that's one of the things I want to give a lot of, credit and a lot of props to all of our partners who are helping this every day. Because I remember, Dr. Horsburgh, I remember talking, one of our earliest conversations, we were talking about the outbreak of multi-drug resistance in Florida, if you remember, at Jackson. Mm-hmm. And if you remember back then, almost every one of the cases were patients who were diagnosed with primary TB who got, treated, and then failed. And they failed because we weren't doing a good job of public health. We hardly see that anymore. I call that homegrown. We hardly see homegrown MDR anymore in this country. And I think it's a real tribute to our public health system and how well it's done.
I would agree. It has changed, and for the better, but we're still seeing who bring it with them when they come to the U.S.
Without a doubt. I mean, and on the other hand, I remember everybody always talked about the second wave, second wave. And do you still think we're, potentially going to see that second wave? Those individuals who were infected, at least in this country, during higher rates of MDR. Now, years later, I think with, from time to time, see those individuals not nearly as bad as we had once feared or thought.
Yeah, no, it's certainly theoretically possible, but I just by the number of imported cases.
I totally. I think, do we have a question? I see somebody, I don't know if that hand is up, but do we have a question on the phone? If you have a question, we'd love for you to ask it. If you just push *7 to unmute, that's *7 to unmute. So if we, I think we have a Jermaine Jaquette. I think her hand may be up, but I may be wrong. So please, if you have a question, please go ahead and ask. *7 to unmute. All right. Okay. And I wanted to ask you, Dr. Horsburgh, about, it's very interesting to me, just like you stated, and I want you maybe to expound upon it, because I think one of the most exciting things is the potential for these quote-unquote new drugs to reduce the time. And I always thought it was interesting in all these MDR trials that they always use the drug for 6 months, but then they always continue it for another 18 months for, with the traditional therapy. And I think that's why it's very interesting and exciting about the SMART trial and other trials where they're actually treating pan-susceptible cases with these drugs to try to show that if a pan-susceptible case is able to be cured in 6 months, then a patient theoretically who's susceptible to those 3 drugs, 6 months should also work. I mean, I think that may be some of the most exciting research that's being done. Any comments on that?
No, I quite agree. I mean, the real focus is the direct clinical trials are moving is to try and look for 4-month and 3-month regimens. So there's the hope that the PAMZ might actually, and they're going to study it for 4 months as well as 6. So the byproduct of that, even if the 4-month regimen fails, if the 6-month regimen works, we'll try it in MDR TB. It'd be terrific to have a 6-month regimen.
Totally agree. And that's where the price of those drugs may really not, may really become beneficial. When you talk about $36,000 or $24,000, what you read for bedaquiline or delamidid potentially, it's unbelievable high. But compared to 18 months, it may be worth it. And that's where these drugs really may pay off if we can shorten it. Hey, one last question because we're running out of time. Actually, I think Deborah Rod is raising her hand. Deborah, do you have a question for us? *7 to unmute. That's *7 to unmute. Deborah? All right, I think they just wanted a shout out. That's it. Hey, one last question, Dr. Horsburgh, which is that what do you call it? I loved what you said about high-dose INH. I am a firm believer in, those patients who, quote-unquote, have low-level INH resistance, I really do like to add INH. And, the studies out of LA, the studies out of New York and others suggested that there may be better outcomes among these patients. So I guess the question we're having is a couple of questions about what is, quote-unquote, when you're saying higher doses, what are you recommending? What milligrams per kilogram, and how often are you giving it?
That's a good question. I actually don't use it. The low dose, so high dose resistance but low dose susceptibility is not that common. Less than 15% of the patients with INH, quote INH resistance appear to have it. And quite frequently you don't have that information unless you're doing MICs or susceptibility testing at 2 levels. You won't know that you have one of those patients. Nonetheless, if you have a patient and you've done some pretty intensive work and found out that's what you have, I would use it. I don't know. I'm sure the data are there in the Bangladesh regimen as to what that high dose is, but I haven't used it, and it's not at my fingertips.
Yeah, usually what we use is 50 milligrams per kilogram, very similar to what we would use with the twice-weekly regimen.
As opposed to 10.
Week, so 900 milligrams twice a week. And just to answer your question, you're right. In Florida, we do more than 1 level. We do INH at actually 3 different levels. And for those patients who might have, let's say, resistance at 0.1 or 0.2, depending on which testing modality you're using, and then are susceptible, let's say, at 0.4 or 1, we potentially would use it in those cases. And more recently, where we're really using it is in patients who have INH-A mutations, which traditionally show a low-level INH resistance and an ethionamide resistance. So in Florida, where we routinely now do, molecular susceptibility on all of our smear-positive, PCR-positive cases, we'll have those results within a day or two. And those are the cases where we will switch until, pending the conventional susceptibilities. And again, which is the whole other talk, the molecular, diagnostics is really making a difference. And I guess I'd like to end with this last question for you, which is moleculars more and more are really, depending on any word yet on any of the, when we do see resistance, I know recently, there's a lot of talk about some mutations being seen with bedaquiline, but they weren't clinically, necessarily correlating. Do you think, in addition to having new drugs, that we will find mutations for these drugs that will help us early on, say, if these organisms are susceptible or resistant?
Well, there have been a couple of resistance mutations identified for both bedaquiline and delaminid. There aren't any tests out there yet, and there certainly aren't any rapid tests, but it's something that can be done. What I don't know, and what is the critical issue, is how many different resistance mutations are there, and how complicated would it be to develop a rapid test. So the GeneXpert for rifampin works because there's a very limited number of rifampin mutations that the test can look for. It's been more problematic with fluoroquinolones because there's a larger number of mutation sites, but the company is actually working on a fluoroquinolone resistance test that could be used in the GeneXpert as well. So we may get there.
Dr. Horsburgh, I cannot thank you enough for this outstanding talk. I have to say, that's, right now, what's beautiful is that we've learned so much, but there's so much more we're going to go in. I'm hoping real soon we'll get you back and you'll give us another update. But I can't thank you enough. I think it's an exciting field, and again, I want to, just again, use this moment to thank everybody on this call for everything they're doing for TB, because obviously right now we're really, I think doing a very good job. We're seeing the cases come down in the United States at least, and also we're seeing, less MDR cases. But, I am really concerned that unless we address these issues internationally, that we're not going to, this is going to be a battle that's going to continue to be fought. And so, Dr. Horsburgh, thank you so much for everything. We can't thank you enough.
My pleasure.
What I'd like to do is thank all of you for joining us today. We really appreciate it. We will be speaking to you, I think, real soon. We have a couple of programs coming up that you saw on the slides, and we'll be having grand rounds in the upcoming months. So I really want to start and say thank you again. We wish you the best. Have a great day, great couple of months, and we can't wait to be back together, discussing TB. So everybody, thank you very much from the SNTC. If we could ever be of any help, please give us a call. Thank you again. Bye-bye now.
Goodbye and have a great day.